Hello guys. So now we have come to the last part of our series, that is we'll discuss about obstetrics and gynecology. So here we'll discuss about obstetrics. Okay. So to begin with, we'll go for reproductive embryology. So let us see how the sexual differentiation happens in human beings. Okay. So we learned, right, in the first beginning chapter, that is embryology. So there is a SRY gene that will be there in the P arm of the chromosome. So based on that only, so the basic division of the gonads will happen. Okay. So the thing is, so everyone will be having Wolffian duct and the paramesonephric duct. Okay, so we discussed this about this embryology in genitourinary system itself, right? So there is Wolffian duct and paramesonephric duct, or the Mullerian duct, in everyone. Okay, so now there is gonads. Based on gonads, so it will be SRY, so basically XY or XX. Okay, so XY will be having the SRY gene. So what happens is, so SRY gene will develop into testis. Okay, so the gonads will be differentiated into testis. Okay, so now the gonads with XX as the chromosome, so what happens is they will develop into ovaries. So what happens is, so testis will start inhibiting the Mullerian duct. Okay, so testis will start inhibiting the Mullerian duct through Sertoli cells. Okay, so what happens is, these Sertoli cells that are present in the testis, there are two types of cells in the testis. Okay, Leydig cells and the Sertoli cells. Okay, so Sertoli cells secrete something known as Mullerian inhibitory factor and will inhibit the development of paramesonephric duct. So what happens is, so all the internal female genital organs will be not produced. So that is why, and all the male genital organs will be produced. So this is how the sexual differentiation happens. Okay, so whereas in ovaries basically secrete estrogen and also testosterone. Okay, so ovaries will secrete two hormones. Okay, in testis it is only the testosterone that will be secreted, not the estrogen. So now coming to estrogen, so estrogen basically develops all the external female genitalia and breast and all. So in testosterone, so testosterone basically acts in the on the secondary development of pubic hair, axillary hair, and all these things. Okay, so here in male side, the Leydig cells were the ones who are secreting the testosterone, right? So it will give rise to all the male internal organ and the external genitalia. Okay, so male internal organ development and the external genitalia, all the secondary sexual characters will be increasing its size and all with respect to so basically Wolffian duct is the one which develops all these things. We learnt it in the genitourinary embryology, right? So testosterone stimulates this action. Okay, so that is the thing with respect to how the XY and XX will decide how which gonad has to be produced. Okay, the now so Wolffian duct remnant in female will be known as Gartner's duct. Okay, so Gartner's cyst, remember, right? So Gartner's cyst will be in the lateral pouch, so lateral wall of the genitals. Okay, so lateral wall of the genitals is where the Gartner's duct will be. So this is the entire embryogenesis of or the sexual differentiation that takes place. Okay, so now let us move on to the basics of reproductive physiology. So we all learned that oogenesis will occur in ovary, whereas the spermatogenesis will occur in the testis. Okay, so spermatogenesis, okay, has to undergo something known as spermiogenesis. Okay, this all takes place in the uterus, please remember. Okay, so it is taking place in the uterus only, just before the fertilization happens. Okay, so what happens is, there are two types of reaction: capacitation and acrosomal reaction. Capacitation just happens like 7 hours before it fertilizes. So basically it matures the sperm. Okay, it happens in the fallopian tube. Okay, so basic mechanism that is happening is, basically glycoprotein coat and the seminal protein are removed, okay, from the sperm. Okay, so basically it is preparing the sperm to fertilize. So then acrosomal reaction is where, after the sperm penetrates, so what happens is, the enzymes acrosin and trypsin are released to penetrate the zona pellucida of the egg. Okay, so there is a layer called zona pellucida. So this is what is happening. So the next reaction is basically zonal reaction. So entire process is known as acrosomal reaction. Okay, so here please note that calcium is important for this acrosomal reaction. Okay, so this is what is happening in the uterus. Okay, so in the uterus, in the female reproductive organ with respect to the sperms. Okay, so now moving on to the specifics of anatomy. So reproductive organs in the female. Okay, so we are discussing obstetrics, right? So we'll discuss the uterus. Okay, so important points are the site of fertilization, we all know, right? The large area, that is ampulla of the fallopian tube. Okay, ligaments of uterus is very very important. Okay, so infundibulopelvic ligament, so it connects ovary to the pelvis. Then ovarian ligament connects ovary to the uterus. Okay, then coming to round ligament, uterus to the labia, we discussed it. This is a content of hernial, I mean inguinal canal in female. So we had discussed when discussing hernia, right? So with respect to what are the contents of inguinal canal. So in female it is going to be the round ligament, that is the content, whereas in males it was the spermatic cord, right? So in that way. Then the other ligament is broad ligament, which connects the uterus to the lateral pelvis. Then the cardinal ligament, cervix to the lateral pelvis, and uterosacral ligament, cervix to the sacrum. Okay, so this is very very important. Okay, so this round ligament is what causes the, so basically it is coming from the uterus and is moving anteriorly, right? So this is what causes the anteversion. Okay, so anteversion of the uterus is caused by round ligament, whereas the anteflexion is caused by tone of the uterine muscles. Okay, then coming to physiology, the basic obstetrics physiology is the implantation happens on the 6th to 7th day after post fertilization as blastocyst. Okay, it will attach as a blastocyst. Okay, so there is something known as integrin gene, which is the gene that helps in implantation. Okay, please remember integrin gene. Okay, so now that the blastocyst has been implanted into the uterine wall, so what happens is, so there are two things that happens. One is the blastocyst will develop into inner cell mass. Okay, one is inner cell mass, the other one is tocoectoderm. Okay, so inner cell mass will become the embryo. So all the fetal tissue will be developing from the inner cell mass, where the outer tocoectoderm will form the fetal part of the placenta. Okay, so fetal placenta will develop from this. So there are two parts for this, that is cytotrophoblast and syncytiotrophoblast. Okay, so these are the parts of fetal placenta. Okay, so please note, inner cell mass contributes to the inner cell mass will contribute to the maternal contribution, whereas the tocoectoderm, okay, will be the paternal contribution. Okay, so basically what I'm trying to tell is all the inner cell mass will be, which will develop into embryo, will be from the mother. Okay, whereas the tocoectoderm, the fetal placenta that was formed, will be paternal contribution. This is very very important point. The reason I'll tell you later when we are discussing a pathology called hydatiform mole, so, and choriocarcinoma also. So please remember this thing. Okay, so the paternal and maternal contribution. Okay, so I'll tell you again. So then coming to placenta, I told you, right? So the placenta will be having two components, that is fetal component and maternal component. Okay, so fetal component basically it develops from the tocoectoderm. So I told you, right? So it has two parts, cytotrophoblast and the syncytiotrophoblast. Okay, so cytotrophoblast basically creates the cells, and syncytiotrophoblast, also called as Nitabuk's layer, will synthesize and secrete the HCG. Okay, so HCG is very very important for the growth of the placenta and the baby, right? So this is how and we'll also use it for measurement of how the pregnancy is going on and all, right? So this is the syncytiotrophoblast that generates it. Okay, so lack of MHC1 will be there with respect to syncytiotrophoblast. Okay, so there is no MHC1 recognition, so that is why the autoimmune reactions also won't happen with respect to placenta. Okay, so then coming to maternal side of the placenta, so it is known as decidua basalis. Okay, decidua basalis. Okay, so it contains of two layers, that is decidua capillaris and parietalis, decidua parietalis. Okay, so extra edge points with respect to placenta is uteroplacental blood flow at the term will be around 500 to 750 ml per minute. Okay, so almost almost like kidney, so it was 625 1200 ml. So here it reaches almost up to 750 ml per minute uteroplacental blood flow. Then the weight of the fetus is equal to weight of the placenta at the 17th week. Okay, so this is an extra bonus point that I'm telling. Okay, then coming to now that we have discussed about placenta, so let us discuss about the amniotic fluid that covers around the baby. So in the early days, it is the maternal plasma that is forming the amniotic fluid, but in the later stages, it is the fetal urine. Okay, so we discussed, right, fetal urine, if it is not there in Potter's sequence, it is gonna be oligohydramnios, which happens, right? So through fetal urine is what the amniotic fluid will be getting produced from, whereas the clearance of the amniotic fluid is by the fetal swallowing. Okay, so fetus keeps on swallowing. Okay, that is how the amniotic fluid gets cleared. Okay, so the two important points are, so amniotic fluid index, which is about 5 to 24 centimeter. Okay, so 5 to 24 centimeter is the normal amniotic fluid index. If it is going to be less than 5, it is going to be called as oligohydramnios. If it is more than 24, then it is going to be called as polyhydramnios. Okay, so or else we are going to take a single deep pocket. Okay, so in entire amniotic fluid, if we are going to take a single deep pocket, it should be 2 to 8 centimeters. That is the normal value. Okay, so these are all important when we are doing the biophysical profile. Okay, so we'll come back to that. Okay, so the basic pH of the amniotic fluid is 7.1 to 7.3. Okay, so this is all and everything you need to know with respect to placenta and amniotic fluid. So now let us see some of the hormones and its importance that are produced in our during the pregnancy. Okay, so estrogen, progesterone and beta HCG. I told you, right, beta HCG is produced by the placenta. So let us see what are all the importance of it. Okay, so estrogen can be produced as three forms, that is estradiol, estriol and estrone. Okay, so estradiol is by ovary. Okay, estriol is what is very very important, that is in placenta, so fetoplacental unit. Then estrone is basically the adipose tissue in all of us. This is the form that it produces in. So what is the function? Function can be divided as before pregnancy and after pregnancy of all these three hormones. Okay, so before pregnancy, development of so basically estrogen helps in development of the genitalia. We discussed it in embryogenesis. So telarchy, then follicle growth, LH surge will happen because of estrogen. Endometrial growth, very very important, endometrial growth will happen because of estrogen. In pregnancy, what happens is it will help in myometrial growth, basically endometrial growth, and the all the muscles of the uterus will also grow with the help of estrogen. Then coming to increased blood flow in the uterine, then breast proliferation is by estrogen, and also RAS activation, okay, to increase the plasma volume. Okay, then coming to oxytocin sensitivity in the third trimester, because oxytocin sensitivity will be increased by the estrogen, so that is why estrogen level will be increased, okay, during the third trimester, which helps in increasing the oxytocin sensitivity, which will be later required for labor process. Okay, so that is why the oxytocin sensitivity will increase in the third trimester. Okay, then please note, if the more than 1000 level of estrogen in fetal sign, so is a well-being of fetus. Okay, so is the well-being of fetus. If the estrogen is more than 1000, so that shows that fetus is good, it's doing good. Okay, so this is the functions of estrogen. Then coming to progesterone, so basically corpus luteum is what secretes the progesterone for up to 8 to 10 weeks, and it is the placenta after the corpus luteum. It is going to be the placenta that takes over the function, and also the fetal adrenal and testes will also produce the progesterone. Okay, so what are the functions? So before pregnancy, it is going to be endometrial glandular secretions will be done by progesterone. Then the spiral artery development, then increased thick cervical mucus will be produced by the cervix, then prevent endometrial hyperplasia. Okay, so this is, will act like an antagonist to estrogen. So that is what is very important in gynecology. Okay, so with respect to endometrial hyperplasia, endometrial carcinoma, to prevent all these things, we use progesterone. Okay, whereas estrogen was increasing the endometrial hyperplasia. Okay, then coming to during pregnancy, it maintains the endometrium and implantation. So that is why it is very important, right? The corpus luteum keeps on secreting the progesterone to maintain this only. Okay, then it reduces the uterine contractility so that the baby can develop, okay, without any hindrance. Then there is a thick cervical mucus that can produce to prevent any infection. Myometrial excitability will be reduced by progesterone. Okay, so it also reduces the oxytocin sensitivity. See, estrogen increased the oxytocin sensitivity, but progesterone is acting against oxytocin sensitivity. That is why this progesterone is pro-pregnant. Okay, pro-pregnancy. Okay, so this reduces the oxytocin sensitivity and reduces the myometrial contraction, so thereby allowing the fetus to grow normally. So when during third trimester, what happens is, so now the baby has already developed, and now it has to be thrown out, right? So it has to be pushed out. So that is why, so progesterone starts withdrawing at the end of the term. Okay, so progesterone will be starting to decrease by the end of the term, and the estrogen will increase the oxytocin sensitivity, and that is when the contractions happen. Okay, so this is the basic physiology. Then coming to beta HCG, very important hormone. So basically it is produced by the syncytial trophoblast. Okay, syncytial trophoblast, the fetal part of the placenta. Okay, so what is its function? So basically it maintains the corpus luteum for a while. Okay, so that the progesterone is very important, right, in the early pregnancy, so that the corpus luteum would produce the progesterone. Then there are two subunits of beta HCG, that is HCG basically. So alpha subunit and beta subunit. Okay, alpha subunit will act like LH, FSH and TSH. Okay, so this has a function of LH, FSH and TSH, whereas beta subunit, that is beta HCG, is what is pregnancy specific. Okay, then coming to the function, main function is basically it stimulates the fetal testosterone. Okay, so one of the important function is it will stimulate the fetal testosterone, so that all the external genitalia, all the secondary sexual characters, all this will develop. Okay, so please note that these are the beta HCG values that will give us the diagnosis. Okay, so if there is a normal intrauterine pregnancy, so beta HCG will be doubling every 48 hours. Okay, so beta HCG will be doubling every 48 hours. Whereas if there is a ectopic pregnancy, what happens is there is a pregnancy rise. So so there will be a rise first, and then there will be a plateau. Okay, so first it will rise and then there will be plateau. Okay, whereas in normal intrauterine pregnancy there will be increase. Okay, every 48 hours it keeps on doubling. Okay, it keeps on doubling. Okay, so in ectopic pregnancy it will rise and plateau. Okay, but in abortion what happens is, so basically it raised but it is falling. Okay, so that is what tells us, okay, so the baby has aborted. Okay, in molar pregnancy what happens is there is a steep rise. Okay, so the value is too much. Okay, so let us see why it happens later. So now please remember, for molar pregnancy, so the beta HCG will be very rapidly rising. Okay, so this is all the important functions of all the three hormones. Okay, so now let us see some of the physical changes or the physiological changes that occurs during pregnancy. Okay, so the systemic changes would be all the systems will have a physiological change that to adapt to the extra so there is a extra being that is in the mother, right? So all the physiological changes also has to be known. So what are the things that happens is, so cardiovascular system, there will be reduced systemic vascular resistance, and there will be increased preload. The stroke volume and cardiac output will also be high. Okay, so please remember that the S3 is normal here, and uterine souffle can be heard. Okay, uterine souffle, all the sounds of the uterus also can be heard. These are all normal features. Okay. Then coming to endocrine system, so the insulin resistance will increase because the mother has to produce leave all the glucose to the baby development also. So that is why there is a insulin resistance here. Then the GI, what happens is there is a little constipation. Then the renal function, there will be increased GFR and reduced blood urea nitrogen. Okay, so please remember. Okay, so please remember, in preeclampsia there is a reduced GFR. Okay, so in preeclampsia there is a reduced GFR, whereas normally there will be increased GFR. Okay. Then coming to respiratory system, there will be hyperventilation. Okay, the diaphragm will get elevated a little bit of 4 centimeter for the uterus to adapt itself. Okay, so uterus size is increasing, so that is why diaphragm elevates a little bit of 4 centimeter. Then coming to hematology, so basically there will be dilutional anemia and increased coagulation will be there. So pregnancy is a procoagulant state. Then there will be increased TABC. Okay. Then coming to skin, so we all know there will be hyperpigmentation, melasma, linea nigra, all these things will be there, right? So there is an increased blood flow to the skin of about more than 500 ml per minute. Okay, so there will be an increased blood flow to the skin. Then this is a normal physiological condition. So the normal weight gain, recommended weight gain should be 11.5 to 14 kg in a pregnant woman. Okay, so this is the normal weight gain that should be there. Okay, so these are all the physiological changes. So the changes that we as doctors should elicit are these signs. Okay, so this is very very important with respect to uterus and cervix. When we do an uterine and cervix examination of a pregnant woman, so these are certain signs which will tell us there is a these are the probable sign of pregnancies. Okay, so these are the probable signs of pregnancy. Okay, so let us see one by one. So Chadwick's sign will tell us so if there is a bluish vagina, okay, when we check for vagina, and if it is a bluish vagina, it is called Chadwick's sign. If it is a pulsatile lateral fornixus, so it is going to be Osander's sign. And softening of the cervix is known as Goodell's sign. Then coming to on pervaginal examination between abdomen and the vagina, if two fingers will be opposing below the fundus of the uterus, so it is going to be Hagar's sign. Then implantation bleeding is there. So around the 5th or 6th day, the implantation bleeding is there, so it will be Hartmann's sign. Okay. Then rhythmic uterine contractions during the pregnancy is known as Palmer's sign. So these are the contractions that we as doctors will elicit. Okay, so it is not the mother that is eliciting. Okay. Then coming to contractions around the 16th and 18th week is going to be called as Braxton's sign. Okay, so these are certain signs. So these are very very important. Okay. Then coming to imaging, so a pregnant woman comes to you, so we will do imaging, right? So these are all the certain important imaging findings. It is very important. Examiners have been interested in asking these questions. Okay, so the first sign of pregnancy will be the intradecidual sign. Okay, so there will be a small bleb that will be there in the intrauterine so intrauterine site. So there will be, this is called as intradecidual sign. This is the first sign of pregnancy. Then coming to yolk sac, so around 5th week it looks like a bleb. Okay, so a bleb sign will be there. Okay, so it looks like a bleb. This is the yolk sac that is present. Okay, if there is a yolk sac plus the amniotic cavity that is being formed, so it is gonna look like double bleb. Okay, so two blebs will be there, so this looks like a double bleb, right? So if there is a yolk sac and the amniotic cavity, so if anencephaly is there, so frog sign, for frog eye, we had discussed, right? It looks like a frog eye. So this is how the anencephaly would look like, or a Mickey Mouse sign is what we tell. So then by spina bifida we discussed in neurology, right? Spina bifida would look like a lemon. Okay, so it looks like a lemon. Okay, then coming to intrauterine demise, what happens is all the cranium and all is getting disorganized. So what happens is it will look like a Spalding sign. Okay, you know Spalding ball, right, in basketball. So this is how the Spalding sign would look like. Okay, so all the so this is basically the skull bones which have been shattered or disorganized. So this is how the Spalding sign would look like. So it tells us there is a intrauterine demise that has happened. Okay, so now coming to importance of our trimesters. So dating scan will tell us the fetal age. Okay, so fetal age through dating scan is what we do. In the first trimester we are going to go for crown rump length, whereas in the second trimester it is going to be the biparatal diameter that we go to. Okay, so then so the number of ideal number of ANC visits is 12 to 13 is recommended. Okay, the calorie intake changes, it is very important, previous year topic, that is so in the first trimester there is no, we won't tell the pregnant woman to change any diet. So in the second trimester we will tell her to add 350 kilocalories more per day, and in the third trimester it is the 450. Okay, 450 kilocalories per day. So this is very important, please remember this. Okay, then coming to chest x-ray exposure, if there is a exposure because of some chest infection and all, we by accidentally there is an exposure, there is no need of MTP, so the pregnancy can continue. Please note this down. Okay, so chest exposure can continue the pregnancy. Then all the live vaccines, all the MR, all these things can be contraindicated. Okay, so these are all contraindicated in live vaccine in pregnancy. Okay, so then so normally in the first trimester only the folic acid can be given. Okay, so only folic acid given. Okay, if anemia is there in the first trimester, so iron folic acid is started. Okay, so basically folic acid is only given in the first trimester, right? Iron folic acid can be given, I mean folic acid is only given in the first trimester, it is not the iron folic acid, because there will be hyperemesis and all. To avoid this we'll go for second trimester iron folic acid. Okay, but what happens is in certain anemia kind of conditions, so we'll add iron in the first trimester itself. Okay, so if there is anemia we can go for iron folic acid in the first trimester itself. Please remember this, this is a previous year question. Now coming to the specifics of each trimester. So aneuploidy screening can be done in each trimester, first and second trimester. So the sample that we take is from the blood of the mother. Okay, so this is aneuploidy screening that we do for a suspected case. Okay, so what happens is in the first trimester we'll take double marker or a combined marker. Okay, double marker or combined marker, whereas in the second trimester it is going to be triple marker or the quadruple marker that we do. Okay, so double marker means beta HCG and PA Papa. Okay, so beta HCG and PA, whereas the combined means it is going to be beta HCG, Papa and NT scan. Okay, so NT scan, so the nuchal translucency means the normal will be less than 3 mm. So basically the nuchal translucency is there, right? So we'll check the thickness of it. Okay, so if it is more less than 3 mm it is going to be normal, but if it is more than 3 mm it is going to be abnormal. So where do we get to see this abnormalities? In Down syndrome. Okay, so that is why we'll do the NT scan in the first trimester. Okay, so please remember this. What is this Papa? It is nothing but insulin like growth factor that is present in the baby. Okay, so insulin like growth factor that is present in the baby will we are basically checking the level of it, so that there is no improper development that is happening. Okay, so this is how we'll check for the aneuploidy in the first trimester. Now coming to second trimester, it is going to be beta HCG, estriol and AFP with respect to triple marker. So these are the triple markers that we do. Okay, then in quadruple marker, so beta HCG, estriol, AFP, and we'll add something known as inhibin A. Okay, inhibin A. Please remember it is the inhibin A. Okay, so what inhibin A does is, so basically it inhibits the FSH. Okay, so that is why we'll see all these 4 levels: beta HCG, estriol and AFP. All these things we discussed, right? All these hormones, so basically it's telling how the baby is developing. Okay. So these are the levels that we see. Okay, so estriol, so coming back to the function, so estriol, I told you right in the beginning itself, estriol is produced by the fetoplacental unit. Okay, so that is why it will tell how the baby exactly is growing. Okay, so then AFP, the alpha fetoprotein, basically what happens is in some of the diseases like neural tube defect or the abdominal wall defect, we discussed right all the abdominal wall defects and neural tube defects. So there will be leakage of AFP. Okay, so leakage of AFP will be there. So that is why AFP will raise in respect to neural tube defect and abdominal wall defect. So that is why we can test this AFP. Okay, so these are the triple markers and quadruple markers. Coming to inference, so in Down syndrome, okay, so how can we infer between the values is, so in Down syndrome there will be beta HCG and inhibin both are raised. Okay, whereas in Edward syndrome, it is going to be both will be reduced. Beta HCG and inhibin both will be reduced. Okay, with respect to Edward syndrome. Okay. So basically all that I discussed here was screening, where we were just screening for aneuploidy. So now if there is a abnormality with respect to all these screening tests, so now I'll have to confirm it, right? So we'll do aneuploidy diagnostic tests. Okay, so that is basically karyotyping, right? So based on karyotyping only we can know whether there is aneuploidy or what is the chromosomal abnormality that is there. So how do we do the diagnosis? So basically we'll do amniocentesis or chordiocentesis or CVS, that is chorionic villus sampling. So please note that chorionic villus sampling is always done only at 11 to 13 weeks. Okay, if it is done less than 10 weeks, it will lead to oromaxillary defect. Okay, so this is very high risk. Okay, so oromaxillary defect is there with respect to if it is done less than 10 weeks. Okay, please, this is an extra edge point, please note this down. Okay, oromaxillary defect if it is done less than 10 weeks old. Okay, so then coming to before diving into the abnormalities in the pregnancy, so let us see the variations that will happen in the placenta. Okay, so please remember the accreta, increta and pancreta. So basically what happens is, if this is the uterus, okay, so if the placenta is getting adhered, right, so accreta will be just adhered to the so basically it should be just dividing from the uterine muscle, but what happens is if it starts invading, these issues will happen. These are the variations. Accreta, increta will be almost in the myometrium, and pancreta will be entire thing will be in the uterus. So it is very difficult, and if we start pulling out during the third part of the labor, so when the cord traction is happening, so entire uterus will come down. Okay, so that is uterine prolapse might happen because of this variations. Please note this down during the pregnancy: accreta, increta and pancreta. Okay, so what are the other variations are? So there are a battle see all this image based thing. Okay, so with respect to the variations, so battledore, circumvallate, bilobed, filamentous, then circummarginate, then securitiate lobe. Okay, so these are all the image based questions that they might ask you. Okay, then coming to placenta previa and abruptio placenta. So what happens is there are three types of placenta previa: marginal, partial and complete placenta previa. In marginal placenta previa there are two types: anterior and posterior placenta previa. Okay, so in posterior placenta previa there is something known as a Stallworthy sign. So before diving into what are the clinical features of placenta previa, so let me tell you what are these. Okay, so for example, this is the uterus and this is the internal os that is there. So what happens is when the placenta is placed in different parts of the uterus, so if it is marginal to the internal os, it is going to be marginal type. Okay, so either it may be anteriorly marginal, or posterior side of the uterus it might be there. Okay, so these are the things. Okay, then coming to partial. Partial meaning, so partially the internal os will be closed, whereas complete meaning the entire internal os is closed. Okay, so this is very dangerous with respect to labor. So that is why we'll have to go for the C-section. Okay, so this is something called as placenta previa. Okay, so basically the clinical features will be bleeding, bleeding PV and painless bleeding will be here with respect to placenta previa. Okay, So the management will be anti-D in Rh negative pregnancies, and McAfee-Johnson regime will be followed. Okay, so to deliver the baby, so McAfee regime, Johnson regime is what is being followed. Please remember this name, McAfee-Johnson regime. So coming to abruptio placenta, so what happens is placenta, there is a early separation of the placenta that is happening. Okay, so there are two kinds. Okay, revealed and concealed type. Okay, so revealed meaning, so there is the placenta is getting separated from the uterus, and so there is on the one side it is connected, but suddenly the reveal is happening, so it leads to bleeding, right? So because here complete blood and all is there, so everything will get be bleeded out, so bleeding will be there, and it is very painful also. Okay, concealed form meaning on the in the center it is getting separated, and on the edges it is connected, okay, to the uterus. So that is why all the blood is pooling in between the placenta and the uterine wall. So there will be no bleed, and extremely painfulness will be there because all the blood is getting collected here. Okay, so that is why it will be extremely painful. It is a severe form, it is an emergency. Okay, so this is the placental variations. Now we'll dive into the specifics of abnormalities of pregnancy, and then we'll go for the labor. Okay, then you're done with the obstetrics. Okay, so we'll go the abnormalities of pregnancies first. So there are preterm labor and postterm labor. What does preterm labor mean? So basically less than 37 weeks, or whatever the labor happens is going to be preterm labor. The criteria to decide whether the labor is happening or not is basically there is 4 contractions in 20 minutes, or 8 contractions in 60 minutes. Okay, then the cervix must be greater than or equal to 2 centimeter that is dilated, and 80% effacement of the cervix should be there. Okay, so this is the criteria that diagnosis is the preterm labor. So coming to diagnosis, we are going to do TVS. Okay, transvaginal sonography is what we are going to do, and we'll see whether the how the cervix is. Okay, cervix laterally should be less than 2.5 centimeter, and U-shaped cervix will be there. So that is how we diagnose preterm labor. And internal os is has been expanded to more than 8 mm. Okay, so now basically it means that the internal os is trying to open. Okay, so this is how we diagnose preterm labor. Okay, there is something called as nitrazine test that we do if there is a premature rupture of membrane. Okay, so to know whether the membrane has ruptured, and also we'll test for fetal fibronectin. Okay, so fetal fibronectin tells the whether the fetus has matured or not. Okay, so this is what we'll do in with respect to preterm labor. So how will we manage is basically progesterone. I told you, right? Progesterone is a pro-pregnancy, okay, pro-pregnancy hormone, which will help the pregnancy to move on. Okay, so if the progesterone is decreased, so it will lead to labor. So that is why we'll give progesterone. Okay, artificially we'll be giving progesterone. Then we'll do something known as cervical circlage. Okay, circlage to prevent the internal os from being opened. Okay, so that will help the pregnancy to continue a little. Okay, so if it is this cervical circlage and all, we'll be doing if it is a very early pregnancies. Okay, so very early labor or very early preterm labor is there. So at 37 weeks and all, we won't do the cervical circlage. Please remember this. Okay, so the procedure that we follow is McDonald's and Shirodoskar's procedure. So that is what I was telling. So before 37 weeks, we are supposed to remove the sutures. Okay, so if it is very near to the if it is very near to the term, we will be not doing cervical circlage and all. So it is in the earlier very early preterm labor is where we do cervical circlage. Okay, so there are many indications and contraindications. If you want, it is an extra point. Please go through this. Okay. Then coming to other management is we are basically giving an antibiotic to prevent the infection that is happening if there is a premature rupture of membrane and all. So that is why the antibiotic of choice is erythromycin we give. Then we will be giving a swab positive. Okay, so if there is a swab positivity, we will be basically sending the cultures also to know whether there is an infection. So if there is a swab positivity, we'll switch the antibiotic to the benzathine penicillin. Okay, so if it is less than 34 weeks, we are going to give tocolytics, steroids, and magnesium sulfate to protect the neurological development. So a magnesium sulfate is given. So probably if it is more than 34 weeks, we are going to go for steroids and then deliver. Okay, so we are going to give steroids for 48 hours and then we'll deliver the baby. Okay, so this is the thing with the management of preterm labor. Now coming to post-term labor. So post-term meaning the fetus has caused more than 42 weeks and still the labor has not occurred. Okay, so please note the amniotic fluid will be almost saffron color in the postpartum babies. So management will be based on the Bishop score. Okay, so Bishop score, if it is more than 8, it is of favorable for induction. So that is why we'll do induction. Okay, so how do we do the induction is we'll augment. Okay, so augmentation will be by artificially rupturing the membrane and we'll be giving oxytocin. Okay, so artificial oxytocin is given. Okay, so then we'll also give misoprostol. So misoprostol basically is a prostaglandin. Prostaglandin will irritate the uterus and so the contraction starts happening. Okay, so basically we are augmenting ourselves artificially. Okay, so this is where we use. Okay, then the misoprostol can be used 50 to 100 micrograms every 4 hours can be given and maximum of 6 doses can be given. Okay, so please note that this is the augmentation that we do. Okay, so then a Bishop score, if it is less than 5, then we are gonna so basically what we are trying to elicit is how the cervix is, whether it is favorable for delivery or not. Okay, so basically we are ripening the cervix. Okay, so dinoprost, the PGE2 can be given if the Bishop score is less than 5, and then we are artificially ripening the cervix. Okay, so cervical ripening will happen. Okay, so this is how we do the management of a post-term baby. Okay, so then I told you, right, there is something called as hydatiform mole. So okay, molar pregnancy. Okay, so what happens is, so this is basically the cystic swelling of the chorionic villi and proliferation of the chorionic epithelium. So what happens is, let me tell you the pathogenesis and then I'll tell you the clinical features. So pathophysiology, basically there is abnormal fertilization that has happened. Okay, so abnormal fertilization means, so there is an empty egg is there is no nucleus at all. So the sperm comes and fertilizes it. So there is no nucleus in the center and there is no maternal content only. Okay, so only the paternal content is there. So what happens is, paternal content starts dividing on its own. So there is too much of paternal content, so excess paternal genome is there. Please remember, I told you, right, in placenta development, in the placenta development is the paternal a function, right? So paternal genome function is basically the fetal placental growth. Okay, so if there is no control from the mother side, so excess paternal genome is there, what happens? So there is increased amount of trophoblastic growth, right? So the placenta from the fetal side, the fetoplacental growth is very high. Okay, so too much growth is happening, which will lead to hydropic degeneration of the chorionic villi. So this is what is happening, the basic pathophysiology behind this hydatiform mole. Okay, so there will be increased beta HCG because placenta is what is generating HCG, right? So there will be increased HCG and there might be increased TSH and the theca lutein cyst also can increase. So HCG is what maintaining the corpus luteum and theca lutein cyst. So if there is increased HCG, so all this will proliferate, right? And also I told you, right, so alpha subunit of HCG will be will act like TSH, FSH and LH, right? So that is why TSH is also increased. So that is why it can be it can act like a hyperthyroid state in this hydatiform mole or the molar pregnancy. Okay, so let us see the variants of the molar pregnancy. Before that, let us see the clinical features. So basically there will be bleeding per vaginum, then MSS will be there, then uterine enlargement, too much too much enlargement will be there. Okay, then there will be pelvic pain and pressure that is there. Okay, so let us see the forms of hydatiform mole. So that is two types, that is complete mole and partial mole. Okay, so here in complete mole, it means that the empty ovum is there and the sperm has infused the empty ovum, and this leads to 0 and 23 X and 23Y. Okay, so this will start duplicating, and there will be only the paternal genome that is present. 46XX and 46XY will be only the paternal form of gene that is present. Okay, here because it is complete mole, it is going to be, there is no fetal parts are there, only the placenta is growing. There is no fetal growth, because fetal part was supposed to grow from maternal genome, right? So there is no fetal growth. Beta HCG will be raised too much. Then honeycomb or a cluster of grape like appearance will be there. Okay, then on USG it is going to be snowstorm. This is very pathognomic to a complete mole. Okay, so please note that snowstorm. Okay, then coming to risk of choriocarcinoma, there is a increased risk, that is up to 2%. There is a increased risk of choriocarcinoma. Okay, so how do we do the investigation and management is basically we'll be doing the investigation of HCG, and based on HCG and USG we are going to go for D&C. Okay, so we are going to do dilatation and curettage, and also we will be always monitoring the HCG levels. Okay, so we to know that whether we have left out any part of the complete mole. Okay, so then coming to partial mole, here what happens is one ovum is there, maternal content is there, but two sperms will be infusing it. So what happens? So basically 46 triple X or 49 69 triple X or 69 XXY or 69 XYY can be the genome that is present in the fetus. So this is very excess, right? Here also basically paternal genome is in excess. Okay, so this is also a problem. So that is where fetal parts will be there, because maternal genome is there, fetal parts will be there, but the placenta is growing too much. So that is why HCG will be there comparatively to compared to complete mole. So HCG will be at an optimum level, but it is raised. Okay, so it is not normal, it is raised. Okay, and coming to choriocarcinoma, the risk is 0. Please remember, choriocarcinoma risk is 0. Okay, so let us now move on to choriocarcinoma. Okay, so basically it is the malignancy of the fetal placental component. So this is a complication of the identiform mole. So there is no chorionic villi that is involved here. It is only the fetal placental component that is increasing its it has become carcinogenic. Okay, so whereas in invasive mole it will be the chorionic villi will be involved. Okay, so please remember that. So what are the clinical features is basically there is an abnormal uterine bleeding. Okay, and there was there was a previous known case of a hydatiform mole was there, and all these things will be the features. Okay, so beta HCG, all this will be raised, dyspnea will be there, hemoptysis and all these things, okay, can be there. Hemoptysis is very pathognomic. Please remember, the reason is there will be a spread hematogenously to the lungs. Okay, so this cancer can spread hematogenously to the lungs. Okay, so X-ray will be cannonball appearance. So cannonball appearance will be there on the chest X-ray. Okay, so this is the metastasis that can happen. Okay, so in the lungs. Then how do we manage this? Basically we'll give the methotrexate. This is the first line that we give. Then EMA co-regime can be applied. Okay, so EMA co-regime can be applied, but please remember, it is methotrexate is the first line. Okay, in the option they'll be giving methotrexate and EMA CO in as the options. Please remember, it is methotrexate that you have to choose as first line. Okay, so this is all about choriocarcinoma. Okay, so you got it right. So now let us move on to the next topic, that is gestational hypertension, like with regards to preeclampsia, eclampsia, all these things we'll learn now. Okay, so this is the basic classification that we do. So suppose a pregnant woman is with more than 140/90 BP. Okay, so if it is before 20 weeks, so these are the things. Okay, so before 20 weeks, if the patient is there and there is no proteinuria, then it is going to be chronic hypertension. Okay, if there is proteinuria, HELP syndrome and all, so before 20 weeks, it is nothing but preeclampsia superimposed on the chronic hypertension. So the meaning is, so there is chronic hypertension, but if there is proteinuria and HELP syndrome and all, so with the chronic hypertension there was preeclampsia. Okay, so this is before 20 weeks. Whereas coming to after 20 weeks, so if there is no proteinuria, then it is going to be gestational hypertension. Normal basic gestational hypertension is there. If there is proteinuria, it is going to be called as preeclampsia. Okay, the same thing only, but it is going to be before 20 weeks and after 20 weeks. Before 20 weeks, it is going to be called as chronic hypertension, meaning the patient already had the hypertension is what we tell. And if it is going to be after 20 weeks, because of the pregnancy she developed hypertension, so that is why gestational hypertension is what we call it as. Okay, so in preeclampsia the division is severe eclampsia, means that is more than 160/90, and non-severe is more than 140/90 with all this proteinuria kind of symptoms. Okay, so this is how we basically classify gestational hypertension. Okay, now coming to pathogenesis, basically the three main pathogenesis is very important. There is imbalance between dilation and the constrictor. Endothelial damage might have happened due to oxidative stress. Okay, which will lead to anti-angiogenic factor. Okay, so oxidative stress had led to anti-angiogenic factor production, that is SF1T1, TXA2, then endoglin. Okay, so these are the anti-angiogenic factors that have developed, so it is not allowing the endothelium to proliferate. So these are the things that is happened. Then the main thing is the spiral artery. Okay, so there is ineffective vasculature remodeling that is happening because of the spiral artery improperness. So this will also release the anti-angiogenic factor. So the failure of extravillous trophoblast to invade is known as spiral artery related pathogenesis for gestational hypertension. Okay, so it is the extravillous, please note it is the extravillous, not intravillous. Okay, then coming to the complications, so preeclampsia might complicate into eclampsia, that is the seizures in the pregnancy. Then there might be HELP syndrome. Okay, so what is HELP syndrome? This so in the name itself it is there. So that is hemolysis, elevated liver enzymes, and low platelets. Okay, so please try to differentiate between HELP syndrome and AFLP. We'll come about AFLP later. Okay, so please try to differentiate between AFLP and HELP syndrome. Okay, so then coming to the management, so basic investigations and all we'll be doing, and then we'll go for umbilical artery velocimetry. Okay, so that is how we'll categorize the patients how to treat. So basically umbilical artery velocimeter will do, and if it is normal, okay, so then we are gonna go nil intervention or antihypertensives. Basic antihypertensives is what we are gonna give. If it is a reduced diastolic flow, so velocimeter will look something like this. Okay, so this is the normal velocimetry, how it is gonna look like. Okay, so this is the during systole, this is during diastole, is how the waves are. Okay, so for example, if there is a reduced diastolic flow, so if there is a reduced diastolic flow, then we are going to go for 37 weeks of at 37 weeks we are going to deliver the baby. Okay, so we'll be keeping on monitoring and we'll deliver at 37 weeks. Suppose if there is absent diastolic flow, so we'll deliver by 34 weeks. Okay, so this is the thing. So if it is a reverse, if there is a reverse diastolic flow that is happening, if it is a reverse diastolic flow that is happening, we are gonna deliver immediately at 32 weeks. Okay, this is when we basically monitor for gestational hypertension. So immediately we are gonna deliver, so that 32 weeks. Okay, so the management is antihypertensives, I told you right, in cardiology itself. So the safe antihypertensives are nifedipine, hydralazine, labetalol, and methyl-dopa. So these are the choices that we use as antihypertensive. Unsafe ones are ACEs and ARBs. Okay, and also please note the beta blockers, that is atenolol and propranolol are also bad. Okay, during pregnancy. So that is why so we basically use hydralazine or labetalol. Please remember that. Okay, so then coming to MACPI trial. So this is the study that showed that magnesium sulfate reduces the preeclampsia progression to eclampsia. Okay, so in a patient with preeclampsia, if we give magnesium sulfate, it is gonna reduce the complications, is what the MACPI trial. Okay, so this was a study that was conducted. Okay, so please remember, it's the next edge point. Coming to eclampsia management, so what we are gonna do is, we are gonna basically resuscitate the patient. So basically seizure is going on, so what we are gonna do, we are gonna all the procedures and all we know, right? In vivo it was asked. So basically we'll resuscitate the patient, we'll turn the patient to the recumbent position. Then we are going to give IV labetalol. Okay, so IV labetalol is the antihypertensive of choice in the emergency, as a hypertensive emergency is there. So IV labetalol is we are giving. Then we are going for Pritchard regime. Okay, so Pritchard regime is basically, there is also called as Zuspan regime. The important one is the Pritchard regime. Okay, so Pritchard regime, what we are going to do is, there is two things, that two steps. Okay, one is maintenance, one is loading dose, the other one is maintenance dose. Okay, so Pritchard regime is where we are using magnesium sulfate as the drug. Okay, so magnesium sulfate, what we are going to do is, in the loading dose, so first we will give 4 gram. Okay, so, within 3 to 5 minutes as IV. Okay, first we'll give the 4 gram IV MgSO4, and then on each buttock IM we are going to give 5 grams. Okay, 5 grams we are going to give. So this is the loading dose. So totally it is, the loading dose is how much? 14 grams, right? So 5 on each buttock and 4 grams that I gave as a loading dose. So this is the entire loading dose dosage of for Pritchard regime. Coming to maintenance dose, each buttock will be giving 5 grams of 5 gram of MgSO4 4 hours till the 4 hourly till delivery. Okay, so 4 hourly, or else if not delivery, until the seizure stops, until the pregnant woman recovers, is how we are going to continue the magnesium sulfate. Okay, so this is the maintenance dose that we do. So we should be aware of magnesium sulfate toxicity. Okay, so that is why we will be monitoring knee jerk, respiratory rate, and urine output. Please note that if knee jerk stops, then we are going to stop MgSO4. Okay, if the respiratory rate drops less than 16 mm, we are going to stop MgSO4. Then if the urine output is less than 30 ml per hour, so we are going to stop. So that is why it should be more than 30 ml per hour. Then it is going to be more than 16 per minute, the respiratory rate, and knee jerk should be there. Okay, so this is how we'll monitor a patient with Pritchard regime. Okay, so if for example there is a magnesium sulfate toxicity that we are seeing, then we are going to go for 10% calcium gluconate, 10 ml in 10 minutes. Okay, so this is the 10 rule of 10 that we give, right? So for calcium gluconate, so this all we would have done in our internship, right? So calcium gluconate 10 rule of 10. Okay, so this is what is the exact thing regarding gestational hypertension. So then now we'll move on to gestational diabetes mellitus. Okay, so how we are going to detect a GDM, or how the patient presents with the GDM is, so basically sometimes what happens is, if a patient comes to you, if a pregnant patient is coming to the clinic, so either we'll be detecting by the RBS value, so that is when we'll get to know that she is having GDM, or probably she will be coming up with some or other symptoms. So so two main things can happen. Okay, so detected by RBS or OGTT, or she will be having some symptoms of GDM, that is UTI might be there, or cardiovite discharges might be there, itching might be there. Okay, then there is a weight gain. She tells there is an increase in weight gain, and also on examination, if there is increased uterus height, so we are going to detect there is polyhydramnios. Okay, so polyhydramnios will be there in respect to GDM cases. Okay, so this is how we so this is how we'll get to know that this person is having GDM. Okay, so coming to pathogenesis, so basically why is pregnancy diabetogenic is, I told you right in the beginning itself, the physiologically insulin resistance will always be there. So the reason why it develops insulin resistance is, so there is a human placental lactogen and increased cortisol or progesterone, and placental insulinase and increased lipolysis, all this contribute for insulin resistance. Okay, then coming to the pathogenesis of macrosomia, so all the GDM babies will be macrosomic babies, right? So why does this happen is, basically when there is increased fatty acid transfer to the fetus, so all the glucose that is there in the mother will also be converted into fatty acids. So these fatty acids also are getting transferred to the fetus, okay, through the placenta. So there is increased fatty acid transfer, and also there is increased fetal insulin, because there is increased glucose that is going into the baby. So to manage that, there is the fetal insulin will also be raised. Okay, so this fetal insulin acts like a growth factor, insulin like growth factor. So that is why the babies will be macrosomic. in GDM mothers. Okay, so please remember that this is the pathogenesis that is happening. Okay, so this hypothesis is known as Penderson hypothesis. This is an extra edge point. Okay, then coming to diagnosis, so basically we will be doing a DIPSY. Okay, so DIPSY is what we do. So first visit at when are we going to do DIPSY is basically at the first visit we are going to do at 24 to 28 weeks and 32 to 34 weeks is where we are going to do DIPSY. Okay, so there are two steps that we can follow. There is the two methods. One is one step method and another one is two step method. Okay, so one step method is where we'll give 75 grams of glucose in 300 ml of water, and after 2 hours we are going to test for glucose. If it is 120 to 140, we are going to categorize them as impaired glucose, whereas if it is more than 140 even after 2 hours, we are going to categorize them as GDM. Okay, then coming to two-step approach, so we are going to do two-step, meaning one is screening and one is diagnostic that we are going to do. So screening, here we are going to give 50 gram of glucose in 200 ml of water. There it was 75 grams, right? So here 50 gram of glucose. After 1 hour, if we are gonna see a value of more than 130, we are gonna tell it as GDM. Okay, whereas after the screening, so we'll categorize them to diagnosis. So here we are gonna give 100 gram of glucose. There it was 50. Again here it was 100 gram. We are giving. We are basically doubling. So if it is in 1 hour, if it is more than 180. Or if it is in 2 hours more than 150, if it is in 3 hours more than 140, we are going to categorize them as GDM. Okay, so this criteria is known as Carpenter-Coston criteria. Okay, Carpenter-Coston criteria is how we diagnose the GDM. Okay, so then coming to one of the other thing with respect to GDM is overt diabetes. Okay, overt diabetes means if the RBS is more than 200, FBS more than 120 and HbA1c more than 6.5 at the first visit itself. Okay, so that means that the pregnant lady was already a diabetic mellitus patient, but she has conceived. So this is overt diabetes. So now it was not the pregnancy or the pregnancy physiological change or the insulin resistance that led to the diabetes. It was previously, even before conceiving, she was diabetic, but now is now is she getting detected about or she is getting investigated for GDM, I mean diabetes. So this is the thing for overt diabetes. Okay, then how do we manage the patients of GDM? So basically our target should be preprandial less than 95 should be there, postprandial less than 120, HbA1c should be less than 6%. Okay, so we are going to do dietary management, that is for 2 weeks. We are going to tell first when we diagnose the GDM itself, we are going to not give metformin therapy. We are going to do dietary regime for 2 weeks. Okay, medical therapy will be started after 2 weeks only. Okay, so metformin for 20 weeks. Okay, I mean after 20 weeks we are going to give metformin. If it is below 20 weeks, we have if the mother has developed GDM, we are going to go for insulin. Okay, or else when we so the reason why we are choosing insulin is if the RBS level is more than 200 mg per deciliter. So this is where we can choose insulin, and metformin most of the people will be more after 20 weeks only, unless otherwise if it is a overt diabetes. Okay, so metformin is what we give. So then coming to delivery, we are going to deliver by 40 weeks. So if there is no complications, we are going to deliver by 40 weeks. Okay, what are the fetal complications that might happen with respect to GDM is, okay, so pre-gestationally sacral agenesis might happen. Okay, then in fetal complications there will be hypoglycemia, after the deliveries, though these are certain fetal complications that might happen. There might be hypoglycemia, hypocalcemia, and neural tube defects might be there. Then macrosomia, as I discussed. Okay, so then there will be shoulder dystocia that might happen. Okay, so macrosomia, how do we do the macrosomia delivery is, so basically so this is based on the guidelines. So if the baby is 4.5 kg, then we are going to go for SVD. Okay, so spontaneous vaginal delivery. If it is more than 5 kg, we are going to go for LSCS. Please remember this guidelines. Okay, with regards to how we are going to manage a macrosomia baby. This is a previous year question. Okay, so that is all with respect to gestational diabetes mellitus. So now we'll move on to anemia. Okay, so Anemia. So based on Anemia Mukt Bharat, please remember this table. Okay, this is very very important. Okay, so anemia, in Anemia Mukt Bharat, there is something called a 6 into 6 strategy. So now it has been changed to 7 into 7 strategy. Okay, so this is the thing. So in pregnant women, so we'll be giving 180 plus 180 days of iron folic acid. So this is 60 mg of iron tablet, and folic acid is 500 microgram. Okay, so this is 60 plus 500 that we are gonna follow. That is for 180 days of pregnancy we are gonna give, and then again we are gonna continue for 180 days. So this is 180 plus 180 strategy for pregnant women. Okay, so we are gonna categorize them as mild, moderate, and severe anemia. So mild anemia means 10 to 10.9, then moderate will be 7 to 9.9, and severe will be less than 7. Okay, so mild to moderate, how we are going to manage is, so we'll be dividing whether the patient is less than 34 weeks or more than 34 weeks. Okay, if it is less than 34 week pregnancy, so we are going to go for 2 tablets, basically 60 mg only, but we are going to go for 2 tablets per day. Okay, so it was 1 tablet that we were giving for every pregnant woman. We are going to give 1 tablet. If there is anemia that is defected and it is a mild moderate stage, we are going to convert it into 2 tablets. Okay, then till the hemoglobin improves, we are going to do this. Okay, if it is a more than 34 week pregnancy, we are going to go for parenteral route. The oral route is not enough. Okay, so that is why we are going to go for parenteral route. It can be iron sucrose, FCM, can be given. Remember, right, in internship on Saturdays we used to some PGs would tell, please monitor this patient for this transfusion and all. It used to be a headache for us. So this is the thing. Okay, so more than 34 weeks when we used to use this method, that is iron sucrose and FCM. Okay, that is ferric carboxymaltose. Okay, so then coming to severe cases, so severe cases will be dividing as more than 5 mg or less than 5 mg per deciliter. The HB value is, if it is more than 5 mg, so if it is a less than 34 week, we are going to go for parenteral, or if it is more than 34 weeks, we are going to go for blood transfusion. Okay, and in less than 5 mg, we are going to go for transfusion. So this is how we can manage the patient. So in severe cases, there is no use of oral drugs at all. So we are going to go directly for parenteral route, or we are going to go for transfusion based on the gestational age. Okay, so please note that for folic acid supplementation before conception, okay, will be 400 microgram in low risk cases, whereas in high risk cases we are going to go for 4 mg or 4 mg dose, because high risk cases meaning if the patient is a long-term valproate user or a lithium user because of some psychiatric condition and all of or suppose she is a known case of status epilepticus and all, so she'll be on certain drugs or certain things. Okay, so that is where, or if there was a previous condition of previous known condition of neural tubular defect that had happened in the previous pregnancy, and all these cases are high risk pregnancies. Okay, high risk pregnancy with respect to folic acid. So that is why we are going to go for supplementation of 4 mg. Please remember this 4 mg thing. Okay, so this is very important. Okay, then coming to the anemia is done. Please remember, this is the 7 into 7 strategy that is now in the current practice. Okay, this is that is not 6 into 6. We used to learn for 6 into 6. So now it has been changed to 7 into 7. Okay, so now let us learn about twin pregnancies. So what happens is, so please remember the table of 4. Okay, so table of 4, if you know, so it is easier to know the type of twin pregnancy that might occur. So in the 1 to 4 days, okay, 4, 8, 12. Okay, if the cleavage is happening on the 4th between in less than 4 days, it is going to be dichorionic diamniotic, which will be the most common type. Okay, if it is less than 8 days the cleavage is happening, it is going to be monochorionic but diamniotic, and if it is less than 12 days, it is going to be monochorionic monoamniotic, where if it is less than 16 days, 12 to 16 days, it is going to be a conjoined twin. Okay, so most commonly thoracopagus. Okay, so conjoined twin will be there. Most commonly seen is thoracopagus, where the both thorax of the babies will be adjoined each other. Okay, so important one is ECG. So basically DCDA twin will be lambda sign, whereas MCDA twin will be T sign. Okay, so this is how the ultrasound would look like. Okay, so please go see an image of this. Okay, Then so the important points with respect to twin pregnancy is that if there is a fetal demise, okay, in the first trimester, it is known as vanishing twin. Okay, if it is in the second trimester, it is known as papyresis. Okay, so papyresis is known if the fetal demise has happened in the first trimester, in the second trimester. If it is the first trimester the fetal demise has happened, it is going to be called as vanishing twin. Okay, so in twin pregnancy, the best time to identify the twin pregnancy will be around 11 to 14 weeks, around third month. So this twin pregnancy will be very obvious. Okay, so then there is something known as Helen's rule. Okay, so Helen's rule is there where we can calculate the incidence of twin pregnancy that might occur. Okay, so the most common presentation with respect to twin pregnancy will be vertex only. Okay, so please remember it is going to be vertex only. So that is why we can go for SVD only in most of the cases, unless otherwise if it is a vertex and breach or in that way. Okay, so we are gonna go for it will be vertex only. I'll tell you about the management. Okay, so please remember, if the second twin risks during pregnancy will be cord prolapse. Okay, so second twin risks during pregnancy will be cord prolapse, hypoxia might be there is increased intracranial hemorrhage that might happen in the second twin. Okay, so that is why second twin has highest risk in the twin pregnancy. Okay, so then also we know that, right, twin to twin transfusion syndrome. Okay, where the twins, okay, one of the either twins tries to steal the blood from the other twin when there is a placental issue. Okay, so the placenta is there, so some of the placental issue, there might be twin to twin transfusion which might happen and might also lead to demise of the one of the twin. Okay, so we are gonna do a staging called as Quintero staging. Okay, please go to the Quintero staging and please know all the stages of Quintero staging. Okay, this is very, very important. Okay, so now moving on, for abortion and MTP. Okay, so basically what is abortion is nothing but expulsion of the embryo or fetus. Okay, so embryo or fetus which is less than 500 milligrams. Okay, so less than or equal to 500 grams is what is the abortion. Okay, so what are the causes of abortion? There might be fetal causes and maternal causes. Okay, so most common causes in the first trimester is aneuploidy, whereas in the second trimester it is going to be anatomical abnormality with respect to the fetus. Okay, so this is the fetal abnormalities. And then if there is a recurrent abortion that is happening, please go through the APLA syndrome. Please rule out APLA syndrome. I'll discuss about APLA syndrome. So there will be APLA syndrome if it is a recurrent case. Then congenital syphilis can also cause recurrent failure of pregnancy, that is abortion, and it is not the torch infection. Torch infection doesn't have any relationship with recurrent abortion. It is only the syphilis. Okay, syphilis is only important. Okay, so that might cause recurrent abortion. Then coming to fetal cause, maternal causes of abortion, it is going to be fetal factor, maternal hypoxia might be there, uterine fibroid, and also cervical incompetence. All these causes might cause the abortion in abortion. Okay, so coming to APLA syndrome, I told you, right? So APLA syndrome, the most common cause of recurrent abortion. So what happens is APLA, that is antiphospholipid, is a beta glycoprotein. Okay, it is found in the endothelium and platelets. Okay, so it is a glycoprotein present in the endothelium and platelet. So what happens in APLA is basically the antibodies will bind to these antiphospholipids and cause adhesion, increase in adhesion, aggregation of the platelets. So what the basic function of phospholipids, antiphospholipids, is basically it will reduce the coagulation in the pregnancy. Okay, or it is present in the endothelium and platelets and reduce the coagulation. Okay, so clumping of the platelets. But if there is an antibody, antibodies against this antiphospholipids, so there will be increased clotting that will be happening. Okay, so increased clotting meaning, so there will be placenta, so the placenta will be disturbed, right? So that is when the APLA syndrome might happen. Okay, so there is a criteria for APLA syndrome that is called Sapporo's criteria. Please remember Sapporo's criteria. Okay, so clinically how we will diagnose the APLA syndrome is, see, basically we can diagnose APLA syndrome based on Sapporo criteria by clinical and lab values. Okay, so the clinical way how we can diagnose is, there will be vascular thrombosis, then a normal fetus loss will be there. Okay, at around more than 10 weeks. Then if it is a premature baby, and 3 consecutive abortions less than 10 weeks might be there, then placental insufficiency might be there. So this is how we can clinically diagnose based on the Sapporo's criteria. And the lab values that we take to diagnose the APLA syndrome is anticardiolipins, lupus anticoagulants, and anti beta 2 GP. Okay, so please remember these 3 values. Okay, anticardiolipin, lupus anticoagulants, and anti beta 2 GP. Okay, so please remember all these 3 things. Okay, then coming to management, it is going to be low molecular weight and aspirin is what we give. Okay, in the patient of if the current patient is suspected to have APLA, this is the regime that we follow. That is low molecular weight heparin and aspirin is what we are going to go. Suppose if there is a risk of a APLA mother and she has not consumed it, so we are going to go for aspirin. Aspirin is the prophylaxis that we give in a APLA mother if she wants to consume again. Okay, so this is the thing. Please remember, it is only the aspirin. If it is a current pregnancy that we are talking about, we are going to add LMWH. Okay. So let us go to the types of abortion. There will be threatened abortion, inevitable, incomplete, complete, and missed abortion. Okay, so then there is also called as septic abortion. So let us see one by one. So the major difference I want you guys to know is about inevitable and incomplete abortion. Okay, so in inevitable, the product hasn't come out yet. Okay, so the product of abortion hasn't come out yet. So but it is inevitably it is gonna go for abortion. But in incomplete, the products have come out but incompletely come out. Okay, some or the other part have remained. So in that way, if it is there, it is going to call it as incomplete. Okay, so inevitable and incomplete, please try to differentiate between these two. Okay, then with respect to septic abortion, so this happens because of improper unhygienic MTP practices and all. So it might lead to toxic shock syndrome. Okay, the patient might die. Okay, so there are grades of septic abortion where if it is only the uterus that is involved in sepsis, it is grade 1. Grade 2 is other parts are also involved, and if it is a peritonitis that is happening, then it is going to be grade 3. Okay, so this is all about abortion. So some of the important topics with respect to MTP Act that was enacted in 1971 and has been revised in 2021 March. Okay, please remember these two dates. Okay, MTP1 came into an action in 1971. Now it has been revised in 2021. Okay, so there will be many hundreds of controversies that will be going on with respect to MTP Act. You should be aware. Okay. Then the current guidelines is, if there is less than 20 weeks, it is going to be 1 RMP is enough. 20 to 24 weeks, it is going to be 2 RMPs that are required. And then if it is more than 24 weeks, the court, okay, so we should go to court, and here the court will appoint a board where there will be obstetrician, pediatrician, and sonography. The new guidelines is there also should be a member of state. Okay, so member of state should be in the board. Okay, so these are the 4 people that will be in the board. Okay, with respect to MTP Act. Okay, now coming to methods of termination or the abortion that can be done is basically first trimester, second trimester is 2 different things. Okay, in first trimester we are going to go for mifepristone. Mifepristone acts as an anti-progestin. Basically, I told you, right, progesterone is basically a pro-pregnancy. Okay, if we give anti-progesterone, it is going to abort. So that is why mifepristone will be given. It will be given 200 milligrams per oral. Then misoprostol, which is the prostaglandin, I told you, right, it will irritate and cause the uterine to contract, so that will lead to abortion or medical termination. Basically, it is going to be 800 microgram that we'll give. Okay, we'll be giving it as doses. Okay, 4 different doses, or completely once for all we can give. Okay, this is 800 micrograms that will give we will be giving. This is after 24 hours of giving mifepristone. Okay, so first day we'll give 200 gram of mifepristone, and after that we'll try to we are basically trying to evacuate the demised baby, so or the demised product of consumption. Okay, so this is with regards to first trimester. If there is a second trimester, so what we are going to do is same as above. or we are going to go for misoprostol only for 5 doses. Okay, so I told you, right? So here we had used mifepristone. Here in the second trimester we can go for only misoprostol thing also. Okay, only misoprostol management also. And also we are going to go for dinoproston, so to ripe the cervix. Okay, so we are going to go for vaginal suppository, which is 20 mg. Okay, so and also we can go for concentrated oxytocin, okay, to induce the labor. Okay, so that is the thing with respect to the management of termination. In third trimester we can't do termination, right? I just told you with regards to MTP Act. Okay, so in third trimester we cannot do abortion. So then post abortal antibiotics should be given, that is doxycycline 200 mg. This is to avoid, I told you, right, some of the it might lead to septic abortion and all. So that is why, to avoid that, we are going to go for doxycycline 200 mg. Okay, then coming to ectopic pregnancies. So I told you, right, ectopic pregnancy meaning, so there will be beta HCG rise and it will suddenly be plateaued. Okay, if it is not a intrauterine pregnancy that is happening. Ectopic meaning it is not a intrauterine, elsewhere the pregnancy has happened, it is going to be ectopic pregnancy. The most common cause of ectopic pregnancy is previous pregnancy, previous ectopic is there, or if there is a surgical tubal procedure that has happened. Okay, so some or the other tubal procedure, if it has happened, it is gonna cause ectopic pregnancy. Okay, the ampullary ectopic pregnancy is 70%, and ischemic is 12%. Ischemic is the most common one to rupture. Okay, ruptured ectopic pregnancy, isthmus is the most common one. Okay, so what are the clinical features with respect to ruptured ectopic pregnancy is there will be basically amenorrhea will be there, pain in abdomen will be there, and there will be MPB. Okay, so per abdomen there will be the abdomen will be tense, tender, and guarding will be present, and rigidity will also be present, just like peritonitis only. So or SPP, so it is going to be all these inflammatory findings will be there. Okay, there is something known as Danform sign, it is called, which is just shoulder tip pain will be there with respect to ruptured ectopic pregnancy. Please remember this, shoulder tip pain will be there. Okay, so on pervaginal examination the fullness will be there. Okay, so on pervaginal examination POD fullness will be there. Okay, these are the signs of ectopic pregnancy. So how do we manage? Basically we are going to divide it as unruptured and ruptured. So unruptured we are going to go for methotrexate IM single dose. Okay, methotrexate IM single dose, just like we had used methotrexate in hydatiform mole, right, for the management of hydatiform mole. So here also we are going to go for methotrexate. It is a IM single dose, which is 50 mg per meter square is the dose that we use. Okay, so or else we are going to go for KCl in the sac. So in the sac itself we are going to go for KCl infusion. Mifepristone can be used for 100 mg, and prostaglandin 2 to 3 mg can be used. Okay, so surgical method of if the medical doesn't work, we are going to go for surgical method, where we'll use linear salpingostomy and linear salpingectomy. Okay, so these are the two procedures that can be done. Coming to ruptured ectopic pregnancy, this is an emergency case, so that is why we are going to we'll have to resuscitate the patient. Okay, this is an emergency, that is why we'll have to resuscitate with IV fluids and all these things. Then the surgical approach is what we are going to go. So it might be open also, and laparoscopy. Okay, so laparoscopy or laparotomy can be done. So basically the management is salpingectomy is what we are going to go for. Okay, so this is with ruptured ectopic pregnancy. Some of the instruments that we use in the MTP is Karaman's. This is with MTP, not abortion. Okay, so what we are I mean, not ectopic pregnancy, just ectopic pregnancy we are going to go for. This is for MTP. Okay, so there is something called as Karaman's cannula, which is a 50 ml syringe. Okay, then there is a manual vacuum aspiration syringe, which will be 60 ml to 660 ml. Okay, then this can be used up to 12 weeks. Okay, so up to 12 weeks of D&C if we are going to do, we are going to go for manual vacuum aspiration syringe. Please go see an image based thing about this. Then coming to suction evacuation, there is a instrument, suction evacuation instrument is there, which is going to use negative pressure of 600 mmHg. Okay, so we'll suck out the products of consumption. Okay, so this is all and everything you need to know with respect to all the abnormalities of pregnancy. Okay, so these are all the important abnormalities of the pregnancy, everything I've taught you. Now we'll go to the last part, that is labor and pph. Okay, so then we are done with the obstetrics. Okay, so then now coming to labor. So before going into labor, we are supposed to know some of the important points with respect to female pelvis and fetal skull. Okay, so female pelvis, the smallest diameter in the female pelvis will be the sacrotyloid diameter. Okay, so sacrotyloid diameter is the smallest diameter that we can see, that is 9 to 9.5 centimeter. Okay, so then there are conjugates, we know that, right? So true conjugate, obstetric conjugate, and diagonal conjugate. True obstetric conjugate is what is very, very important, that is the diagnostic that we do. Okay, so this is 11, 10 and 12 centimeter. Okay, true conjugate, obstetric conjugate, and diagonal conjugate. So please remember this 11, 10 and 12. Okay, then coming to types of pelvis, you should know to identify based on the images. So gynecoid pelvis, anthropoid pelvis, platypoid pelvis, and android pelvis, which can be seen in males, most commonly in male. Also in female also can be there, which might lead to some cephalopelvic disproportion. Okay, so then fetal skull, go see the all the diameters of the fetal skull. Okay, so based on the images you can identify the fetal skull diameters. Okay, then coming to the proper labor, so we are gonna start with induction of labor. Okay, so induction of labor, I told you, right? So we are gonna go for Bishop score. So Bishop score, so if it is less than or equal to 4, where it is unfavorable, 5 to 8 it is moderately favorable, whereas more than 8 it is favorable. So meaning, so the cervix has ripened. Okay, if it is not ripened, we are gonna artificially ripen if needed. Okay, if it is a post-term labor that we are talking about, we are gonna go for artificial ripening, where we use dinoprostone and all, right? So this is the Bishop score that decides it. Then what are the methods of induction is, we are gonna go for misoprostol. Okay, so 25 micrograms of misoprostol can be given, or we'll be artificially stripping the membrane. Okay, then also in polyhydramnios cases, we can go for amniocentesis. Okay, amniocentesis will lead to irritation and cause the it will cause labor. Okay, so then the oxytocin. Okay, with oxytocin we can go for amniocentesis. Then what are the uterotonics that can be used to promote the contraction is oxytocin, methergin, and carboprost, and also misoprostol. Please remember all these 4 drugs. Okay, so these are called uterotonics. Whereas the tocolytics, where we use it, where do we use tocolytics to reduce the contraction is in preterm labor. So here basically we are trying to avoid the labor to progress, so that is why we are going to use tocolytics, where the magnesium sulfate, nifedipine, beta 2 agonists, then NSAIDs can be used. Okay, so beta 2 agonists, that to terbutaline. Okay, so that we use in asthma and all, right? So this also can be used as a tocolytic. Okay, so that is all with respect to induction of the labor. So now let us see the biophysical profile. So basically what we are trying to do is, before induction of the labor, so when the patient is in the first stage of labor, we are going to go for, or suppose the patient has visited to you in the later part of the trimesters or at the end of the term, we are going to go for biophysical profile. Okay, to know how the fetus is doing. Okay, the basically fetal well-being is what we are going to take into account. So suppose if the labor is going, this is what we are going to do, biophysical profile. So please remember, this is Manning score that we do. Remember the ban motto. Okay, so remember the mnemonic ban motto, which means, so breathing, amniotic fluid, single pocket, NST, movement, and tone is what we see in a baby. Okay, so we are going to give 2 points for each of them. Normal means it is going to be 8 to 10 points. If intervention is needed, then it is going to be less than 5 is where we intervene. Okay, so if there is a less than 5 score, that means the fetus is in distress, so that is where we are going to go for intervention, probably LSCS or something like that. Okay, so this is the biophysical score. Okay, there is modified biophysical score, where we don't use any of this, we are just going to use NST and AFI. Okay, so that is amniotic fluid index. Okay, so this is what we are gonna use. Okay, This is the biophysical profile during the labor that we use. Okay, so then coming to partogram. You know that, right? Partogram and all, we'll be doing. This is the charting that we do with respect to labor progression that is going on. So there is modified WH partogram, that is what we all should be aware of. So there is no latent phase in the modified partogram. So there are stages of labor, right? I'll explain it to you. So here there is no latent phase. Then vaginal examination is done. Then charting will start from 4 centimeter. Okay, so 4 centimeter of cervical dilation is where the starting the charting will start. Okay, please note that this is for our guidelines, whereas for WHO labor guide for nursing students or nurses, they have given it as it starts at 5 centimeter. Okay, so at 5 centimeter they have given it in nursing chart. So please read the question if they are telling about nursing chart that they are talking about. So if it is gonna be 5 centimeter. Here also it is the WHO that has given the guidelines. So there also it is the WHO that they have given the guidelines. Okay, so please remember that. Probably it is for their charting. For nurses chart, it is going to be the 5 centimeter they are going to start the charting at. Okay, so please be aware of this. Okay, then coming to important conditions and readings of CTG. So CTG has different forms, right? So these are the conditions. Okay, so if there is a early deceleration in the CTG, it means that there is the head compression. Okay, so early deceleration is there, means there is head decompression, whereas late deceleration is there, means there is uteroplacental insufficiency, probably oligohydramnios. Okay, then if there is a varial deceleration, it means that there is cord compression. This is emergency. Okay, so this is where we should be panicking. Okay, so oligohydramnios or cord prolapse and cord around the limbs, all these things might lead to variable deceleration. Please remember this. Early deceleration, head compression is happening. So late deceleration, so basically uteroplacental insufficiency is there, variable cord compression is happening. That is when we have to intervene. Okay, so management is, so basically if there is a cord compression, what we do is change the maternal position and then again do the CTG. Okay, first thing is we'll change the maternal position and do the CTG, and what we are going to do is basically resuscitate oxygen and IV fluids will be giving, and we'll be trying to amnio infuse. Okay, we'll be giving amnio infusion. Okay, so if it is not under labor that is happening, so we're going to go for amnio infusion. Okay, so now we'll go for the specific of labor, that is the stages of labor. Okay, so first stage is basically onset of labor to 10 centimeter is the first stage of labor. Okay, so there are 3 stages of labor. So now that is 4 stages. So but now we will start talking about first stage. Okay, so it is basically onset of labor to 10 centimeter of cervical dilation is the first stage. Okay, so it is the fetal ACTH that triggers the labor. Please remember, it is a fetal ACTH that triggers the labor. So basically fetal ACTH, adrenocorticotropin hormone, is telling mother, I have developed completely, now you can start pushing me out. So this is the fetal ACTH that tells the onset of labor. Okay, so now there are 2 phases, I told you, right? So latent phase and the active phase of labor in the first stage. Okay, so latent phase is 0 to 4 centimeter, whereas the active phase is 4 to 7 centimeter. Okay, there is also something called as transition phase. Okay, so which is 8 to 10 centimeter. Okay, but we consider active stage as 4 centimeter to 10 centimeter. Please remember this. Okay, so transition phase in some of the guidelines has been given, but mostly it will be considered as a phase of active phase only. Okay, so these are the normal hours that might be there. So 10 to 12 hours in primary mothers and 6 to 8 hours in multi-gestation, where the latent phase. Whereas I mean in primary it is going to be 10 to 12 hours it is going to be there. Okay, so this how are they going to present to you with is basically in active phase regular contractions will be there, and in transition phase is where the intense and pain will begin. Okay, so 8 to 10 centimeter cervical dilation is where the pain it will be very painful and intenseness will be there. We have all seen in labor room, right? So this is the transition phase that the pain and all will occur. Okay, so please note that we'll consider that the active phase is in arrest when there is no descent at all for more than 1 hour. Okay, so more than 1 hour is the golden time period. So if it is not happening, then we'll think that the first stage arrest has happened. Okay, so there is no progression at all. So that is when we'll go for investigation, and when probably we'll even go for intervention, that is LSCS, or probably will intervene by doing episiotomy and all these things. Okay, so then the second stage is basically delivery of the baby. Okay, so delivering the baby after the now the cervical dilation has happened. Now we are going to go for delivery of the baby. Okay, so this second stage in primary mothers will be around for 1 hour, and multi will be 30 minutes, right? So we have seen in labor room, right? So within 1 hour the baby delivery will happen. Okay, so please remember the mnemonic: every day fire rises extremely. So these are the stages of how the baby delivery will happen. So first thing is the baby's head starts engaging, descent will be there, then the flexion of head happens, internal rotation, then the crowning happens, then the extension will be there, restitution, then the external rotation happens, then the baby will expulsion is happening. Okay, so this is the complete stage of delivery of the baby. Okay, so head to shoulder delivery during expulsion should be delivered within 60 seconds. Within 1 minute the head to shoulder delivery must happen, or else the baby might undergo hypoxia. Okay, so we have learnt all about asphyxia and hypoxia in neonatology, right? What might happen if there is a hypoxia that is there. So that is why it is very important. The maneuver that we use to deliver head to shoulder is Ritgen's maneuver. Okay, so please remember this Ritgen's maneuver. Okay, so then after the baby is delivered, it is our duty to deliver the placenta. That is the third stage of delivery. That is active stage of delivery of placenta. That is controlled cord traction is what we do. Okay, so the method that we use is Brandt-Andrew method. Okay, so basically controlled cord traction, we all would have done it, right, at least once in our internship. So basically controlled cord traction is what we do. Okay, so to deliver the placenta. Then coming to recovery, so this is the fourth stage of labor, so which is 1 to 2 hours post placental delivery. Okay, so this is the fourth stage of labor. Okay, here we are supposed to monitor for PPH. Okay, then also initiate breastfeeding. So this is the fourth stage and very, very important stage of labor. Okay, so these are all the stages of labor. Okay, then coming to how we are gonna go for abnormal presentation deliveries, we'll see. Okay, so how are the abnormal presentation gonna be there? So it might be a transverse lie that has happened, or a breech lie that has happened. So breech meaning, so all the babies are supposed to be head down. Suppose if the head is up and the foot is down in the internal os, it is gonna be called as breech. Okay, if the placenta is laying transversely, that is called as transverse lie. Okay, so breech presentation can be frank, footling, and complete breech presentation. Okay, so here in franks, what happens is legs will be up, all the both the lower limb will be extended in the extended position. Okay, so how we are going to do the delivery is SVD. Okay, I'll tell you all the maneuvers that we do. So here we are going to go for vaginal delivery only. If it is a footling, that we are footling breech, for example, a foot has come out from the internal os, so we are going to go for LSCS. Then if it is a complete breech, if it is a crossed leg, we are going to go for ECV. Okay, so please remember, in complete breech, so we are going to go for if it is a crossed leg, we are going to go for external cephalic version. So what is external cephalic version? So basically we are trying to rotate the baby into the vertex position. Okay, so to do ECV, there are some prerequisites. Okay, so before doing ECV, we are gonna give anti-D if it is a RH negative pregnancy that we are dealing with. Okay, so gestational age should be more than 36 weeks. It should be a singleton pregnancy. Well flexed baby should be there. Liquid should be adequate. Liquor should be adequate. That is, amniotic fluid should be adequate. Then the membrane should be intact. The pelvis should be adequate. There should not be any pelvic disproportion. Then there will be no indications for LSCS that should be there. So these are the prerequisites before doing ECV. Okay, the contraindications, the absolute contraindications are the There should be no contraindications with respect to SVD. Then there should be no multifetal pregnancy. Early labor should not be there. Then a premature rupture of the membrane should not be there. Then the cord, we are not going for cord around the neck. If there is a uterine abnormality, that is if there is a diadelphi, or if it is a bicornate or septate uterus, so we are gonna avoid ECV. Then if it is a intrauterine growth retardation, so we are gonna not do ECV. So these are the things with respect to ECV. Okay. Then coming to the maneuvers for breech, I told you, right? So there are some certain maneuvers that we use. So these maneuvers are Burn Marshall maneuver, Pinard's maneuver, Lawsett's maneuver, Marcia Smelly maneuver, Prague's maneuver. So please go through all these maneuvers. Okay, before going to exam, please go through all these maneuvers. Go see a YouTube video on this. Okay. Then coming to cord prolapse, so what are we going to do is, there is something called as Vagos method. What we are going to do is, we will fill the bladder, and so basically in cord prolapse, the first thing we are going to do is okay, so basically we'll release from the stirrups and pull the we'll put the entire lower limb into the abdomen. Okay, so we are going to flex the hips too much into the abdomen. Okay, so that is the first basic thing that we are going to do with respect to cord prolapse. Okay, so please remember that, and after that we are going to go for this Vagos maneuver, fill the bladder and all these things. Okay, so this is how we manage cord prolapse. Okay, all the breech maneuvers are very, very important. Okay. Then in a normal delivery, if forceps or instruments are needed, so this is how we do it. Okay, so these are certain instruments, that is a vent house cup and all the forceps. Let us see. Okay, so a vent house cup will be placed in 3 centimeter posterior to the 3 centimeter anterior to the posterior fontanelle. So suppose this is the skull of the fetus, and here the anterior fontanelle is there, and here is the posterior fontanelle, the triangle shaped. So here the place we are gonna place the vent house cup is 3 centimeter above the posterior fontanelle, is the vent house cup position. Okay. The pressure we are going to use is 0.8 kg. Okay, so negative pressure is the maximum pressure we are going to use, and we'll have to deliver within 3 pulls. Okay, within 3 pulls we'll have to deliver, and it should be within 15 to 20 minutes we'll have to deliver. Okay, so these are the prerequisites if we are using vent house cup. Okay. Then forceps delivery. So basically the forceps are, please go and see an image based questions on this, and also the images of these forceps, that is Piper's forceps, Killian's forceps, and Virgil's forceps. So basically in Piper's, the instrument will be bent. Okay, so bent will be there, and in Killian's forceps, the forceps will have 2 handles. Okay, so 2 handle will be there with respect to Killian's forceps. So please go see an image of it. So now this is what we talked about labor. Okay, SVD and all. So if we are going to go for LSCS might be elective LSCS, and also there might be emergency LSCS that we do. So this is when we are going to do after 39 weeks is where we are going to go for LSCS. So most probably here antibiotic prophylaxis is given, that is cefazolin is the antibiotic of choice that we give before LSCS. Okay, so we are going to give 30 to 60 minutes before LSCS. Okay, so then we are going to go for anesthesia, that is spinal anesthesia is preferred in always, if and unless suppose there is need of general anesthesia in some of the cases. Okay, so spinal anesthesia, epidural anesthesia is what is the choice. Okay, epidural anesthesia, if there is a increased pain and all, so that is when we are going to go for epidural anesthesia. Okay, then coming to incisions, skin incision is called as Fennel style incision, uterus incision is known as Kier's incision. Okay, so this is the incisions that we'll do. Okay, in VBAC meaning so vaginal birth after the cesarean section, if we are gonna go for LSCS, we are gonna give a transverse incision. Okay, so this is the thing with respect to LSCS. So then the last point, that is the postpartum hemorrhage. So now we have learned all and everything about the delivery of the baby. Now we have delivered. Suppose there is a complication post delivery in the 4th stage. I told you, right, there are 4 stages of labor. The 4th stage is where we try to monitor for PPH. So if PPH happens, so let us see how it happens. Okay, so after expulsion of the placenta is when the PPH happens. The etiologies are, if there is a uterine atony, trauma, or retained tissue is there, or coagulopathy. So these are the certain etiologies where the postpartum hemorrhage might happen. Okay. We all would have seen at least one case of this PPH, right? So then coming to criteria, the 2026 guidelines they have released. So this guidelines is very very important. It tells that if there is more than 300 ml of blood loss and we are checking the vitals, and if there is more than 500 ml of so if the more than 500 ml of blood is being lost, that is when we consider it as PPH. Okay, so more than 300 ml, and if there is a vital instability, or if it is a 500 ml blood loss, so that is when we consider it as PPH. This should be occurring within 24 hours. Okay, so how we are going to do the management is E-motive, or it is also commonly known as care bundle. Okay, so E-motive is very very important. So what is the algorithm? I'll tell you. Okay, so the first thing, so suppose you're in the labor room, there's a patient lying down, and suddenly you see that there is a bleeding happening postpartum. Okay, so after the delivery there is a increased bleeding that is happening in that particular patient. Okay, so we'll suddenly call for help. Okay, so we'll call all the obstetricians, then we'll do the resuscitation, basic resuscitation, because it is a hemorrhage that is happening, right? So basic resuscitation that we'll do, we'll connect all the IV fluids, and all the oxygen supplementation if needed, and all these things we'll be doing. The basic resuscitation in an emergency we will be doing. So now based on the cause is how we are going to treat the patient. Okay, so first we'll identify the cause. Okay, so if it is a atony, the uterus is not responding or not contracting at all, first thing we are going to do is massage. Okay, so this is the E-motive that I was telling about. Okay, so E-motive is the management with respect to atony. How we are going to do is, first thing is massage that we are going to do, then we are going to go for uterotonics. Okay, uterotonics, that is oxytocin, carboplast, and methergin. Okay, so please remember, so these are the things that we use for E-motive. Okay, so then we are going to go for tranexamic acid to stop the bleeding that is happening. Then we are going to give IV fluids. Okay, so after this basic resuscitation that we do with respect to hemorrhage, so we are going to go for balloon. Okay, balloon tamponade. Okay, so balloon tamponade is what we do. Then after, if that too doesn't works, then we are going to go for ligation or B-Lynch suture. Okay, so in B-Lynch suture, it is the ovarian and uterine artery that we ligate. So this is the basic management. If any of this doesn't work, then the last resort is hysterectomy. Okay, so first we are going to do all these things, and then we are going to go for hysterectomy. Okay, so then coming to this was with respect to atony. Okay, so E-motive, please remember that E-motive meaning, so it is the emergency case with massage that we do, oxytocin, tranexamic acid, IV fluids that we do. Okay, so this is E-motive. Okay, then coming to, if it is a retained tissue, we are going to go for manual removal of that retained tissue. If it is a trauma that had happened and it is leading to PPH, during the delivery some trauma might have happened. Okay, so that is when that is how the PPH is happening. So that is when we go for the repair, that particular repair we are going to do. If it is a coagulopathy that had led to this PPH, we are going to go for fresh frozen plasma or platelet infusion is what we are going to do. Okay, so this is the basic management that we do for PPH. Okay, please remember the E-motive thing. Okay, so if it is a preeclampsia with the PPH case, a preeclampsia patient has undergone PPH, we are going to go for misoprostol. Okay, please remember misoprostol helps. Then carboplast can be given as a heterotonic in more, and it is the most potent drug. Okay, please remember we should avoid carboplast in asthma. And also please note that in third stage of labor, see I told you, right, the third stage of labor, that is we are delivering the placenta, right? So here during the delivery of the placenta, if the placenta is not coming out even during after the controlled traction, we are going to go for uterotonics. Okay, so oxytocin, misoprostol, and mifepristone, and all this thing can be used. Okay, but carboplast is not I mean, it can be given, but it is not in the guidelines. Okay, so carboprost is not in the guidelines of third stage labor. Please remember this. Carboprost is in PPH, not in third stage labor. Okay, so please remember that. Okay. 0.2 to 2 mg is what is the dose that we give for carboprost. Okay, so please avoid carboprost in asthma. Okay, so and carboprost is the best drug that we can give for PPH. Okay, then there is something called the last thing that after all the delivery and all happens, 6 weeks post delivery is known as puerperium. Okay, so puerperium is the period post delivery for 6 weeks. Okay, here the main thing that we are supposed to know is the uterine positions. Okay, so now the uterus is after the delivery, uterus is trying to go back to its original place. So what happens is, immediately after delivery, the uterus will go and lie at the level of umbilicus. So we are gonna palpate, and we will definitely get to see the umbilicus is palpable at the level of the uterus is palpable at the level of umbilicus, and post day 1 we are gonna get to see less than 1 finger below the umbilicus, day 2 2 finger below the umbilicus, and by day 10 to day 14, by 2 weeks, it will be in a pelvic organ again. So pelvic organ became an abdomen organ, right? So it is going back again, and within 2 weeks it will be a pelvic organ again. Okay, so this is all and everything you need to know with respect to obstetrics. Okay, so I've covered most of everything with respect to obstetrics. Now we'll go for the last and foremost topic, that is gynecology. Okay, thank you.